require one person. You're probably finding it. So where did I leave off? Oh, initial assessments with findings of post-op surgical incisions. Okay. So where did I drop off over here?
Here.
Okay. So wound assessment, discussion of the aspects of wound assessment. And we're going to have the next person do healing by primary intention, the next person doing healing by secondary intention, and then tertiary or third intention healing. Okay? So actions to be done before administering antibiotics for wound infection. I'm trying to remember your name.
Sophia.
Okay, so Sophia, you would talk about the things that the assessments and the actions that the nurse would take before giving medications for antibiotics for wound infection. Okay, this is regarding pain. So neurophysiologic process of pain. We're going to go have you talk about transduction and let me see here. I'm trying to think of how many more I have. So transduction, and you'll do transduction and transmission, and then you'll have modulation and perception. And Holly, you'll have the differences between chronic versus acute pain. And then over here we'll have describe pain medicine tolerance and appropriate nursing actions. And then we'll have you do breakthrough pain and appropriate nursing actions. And then describe the nurse's role in analgesic titration is going to be yours, Joanna. Okay? And I will talk about pain medications for hospice patients since that's my field.
Okay, so I think that the earliest chemical factors, what was that?
She said it was like suturing, like if a stitches break, or if you have like the wrong glue or something.
The signs and symptoms?
And for the actions, letters would take, it's just like, I don't know, almost everything I like the dressing and
The soaking.
yeah. And I'm
Like you
replacing.
don't leave them. You like,
Yeah. Actually, with them, tell them it's gonna be okay.
Yeah.
We'll fix it.
And then you call for help. Like I feel like she was thinking first.
Mm-hmm. People are walking around with dressings and on the ceiling in their pocket, but
We're doing the action stage.
Mhm.
What cause?
they get to here. I need to talk about the food, the analgesic level over here.
Okay, so say if they wanted to make an adjustment, the doctor wanted to make an adjustment of the medication.
Yeah,
So I don't know if that was discussed at all in class.
I like it.
Okay.
Thank you.
So if they wanted to either if the physician wanted to either lower or increase the medication, what would be some of the assessments and actions that the nurse would do to be helpful to that patient?
What are you writing?
I'm doing action.
Oh, okay.
Keep working on this.
I don't know. I'm still writing things.
I'm writing all this down.
I'm gonna rewrite my first answer if you wouldn't change it for that.
Hmm?
I'm gonna rewrite my first answer if you wouldn't change it for that. It's just like shit.
I'm not rewriting shit.
I'm not rewriting. I did.
No. It's okay, we don't care. I told them I can't make flashcards because I'm like so OCD. Like if they don't look good, I'll redo one flashcard. Like yeah, I can't do it.
Yeah.
I mean, honestly, I can find stuff. Like, I didn't get a picture of their answer. It's good. So,
Mm-hmm.
Well, I mean, there's so much stuff on here that I'm not gonna put on here. So just take a picture. You guys already have all this stuff. Or you should.
It's just nice to have a chat about it.
It is.
Just a little chat.
It is. And it's actually probably good to write it out.
Yeah.
It's stick in my head a little bit better.
I know. Yeah. Change the umbrellas and the
What's the difference between the peri-wound skin and wound edges and the condition of surrounding skin?
I don't know.
No?
I think it's the same thing.
Okay.
I thought it was, yeah.
I want you guys to write this down because I definitely want to make sure that you have corrected information. We just talked about this, but I want you to write it down. So I misspoke again when I talked about the cross-reaction with penicillin and mycin. So penicillin, they cannot receive cephalosporins. So examples of that would be like Keflex, Ancep, those things are cephalosporins. They cannot. But they can receive mycins and doxycycline. So I want to make sure that that's clear with everybody since I misspoke. Okay. Is everybody finished with their thing or almost? Take just a minute or two to finish up.
I wrote this down. Dual energy X-ray.
Yeah.
There you go.
No.
For the bus thing. Measures bone density. Bone density and body composition. Talked about
wait a minute.
Okay, so let's go ahead and go back to where we were. Okay, so purposes of wet to dry dressing.
So I have it protects wounds from microorganisms, aids in hemostasis, promotes healing by absorbing drainage and debriding the wound, support and splint wound, promote thermomechanical insulation to wound surface, provide maintenance of high humidity between wound and dressing.
Okay. So when you do those wet to dry dressings, they can be very painful. We want to basically provide some pain medication prior to a patient receiving them. But they do act in many purposes to basically provide a way of doing debridement that's it's kind of like a mild mechanical instead of like scraping and everything that has to be done surgically. So it can help with secondary intention healing, which we'll talk about. What about wound dehiscence and evisceration? I'm trying to remember, did one have dehiscence and one have evisceration? Okay.
Yeah, we both did that one.
Okay.
So, dehiscence is partial or total separation of the wound layers. And in the early dehiscence, you can have that can be from technical factors such as like they did the suturing wrong, or the glue came off, or
the nurse took out the staples too early.
right.
So how you prevent that is like if one is you need to be sure that it's well approximated and well healed, and sometimes it's better with certain patients to take out every other staple and then come back the next couple of days and take out the others. So that way, like people who you're used to seeing fall a lot. So anyway.
And then later, I guess that means like they've had it for a longer time.
Yeah, she said it was common 3 to 11 days post-op.
Oh, okay. So that would be from an increase in stress, such as them laughing or like vomiting. I think that's what I wrote.
So
Or I
by
wrote
splinting that, so if they're coughing or if they're doing some action that may put a lot of pressure on that abdominal wound, we want to teach them about abdominal splinting, like with a pillow, where they're holding the pillow up against that area. Okay? Let's talk about evisceration.
That's when your visceral organs go through the wound. That's after it has dehisced. And signs and symptoms of that is you'll have like a giving feeling, like your organs are coming out of your body, I guess.
Which is exactly what happened.
Yeah.
And what does the nurse do for that?
Soaks a dressing in normal saline to
Okay.
keep the organs moist.
Right, and then calls the
Calls for
physician
help.
right away so they can get that patient back into surgery.
Yeah.
So moist dressing, sterile dressing with normal saline. Yes?
So I was reading in the book, it said to prop the organ with a normal saline, but I think in class you said just cover it, so I wasn't sure which
I
one.
think it would probably be based on the situation. I mean, if there was risk to the organ, like if it's the intestine, of actually getting strangulation or something, they may want to do something like that. Though in reality, you need to get them back into surgery as soon as possible. So definitely covering, and that includes both sides, so
Yeah.
that would also prop up that underside.
Okay.
I think too what it meant, like if the organ actually is more out of the body than it is.
Right.
Don't try to push it back into where it is.
Right. Don't put it
Just kind
back
of
in.
prop
The
it,
surgeon
push
can do
something.
that. Yeah, that's a good point. Thanks, Holly. So, so we actually already discussed that. I'm sorry. So the actions for the patient with evisceration. So who had initial assessment findings for the post-op surgical incision?
I have that one.
Okay.
So you would look at the appearance, the size, if they have any changes in vital signs, drainage amount, is it like small, scant, or is it large? The swelling, if there's pain, if they have drains or tubes, the status of those. Is
if there's any tunneling or undermining, and you're going to look at the incision site and the doctor's orders of dressing changes.
Okay. And so what would we be expecting right after surgery? What would that wound look like right after surgery as a properly healing wound?
Do you see like bruising around it?
Not necessarily.
Redness, like with a little bit of swelling?
Yeah, there's going to be some mild redness and swelling. It may even be warm to touch, but not like what you would see in an infection. But basically, it's that inflammatory process beginning that's actually required for healing. So there is going to be some redness and swelling initially as well. So it may be some temperature change, but it shouldn't be dramatic. I mean, you would know because it's not going to be bright red. It's going to be more pink or light red. Okay. What about, we actually did complete wound assessment. I know that, so that would include the different things to measure for, and I know she talked about some of them.
Yeah, I just said the anatomical location, the stage and depth, which is partial or full, the dimension, and it'd be length times width times depth. Length is head to toe, width is hip to hip, and depth is the deepest part. The borders, if they're diffused, well-defined or rolled, attached or not attached. Peri-wound, which is being around the wound, the condition of that, undermining or tunneling, drainage, appearance of the wound bed, odor or drains, or the closure of it.
Okay. And so, and then you also want to look at, looking at each aspect of it. Did you all talk about staging? Or maybe that was discussed in fundamentals. So, like a stage 1, stage 2, stage 3.
Yeah, we've talked about that.
Okay. What about primary intention wound healing?
So the healing of the wound without tissue loss, the wound edges are brought together, reapproximated. A wound is closed by a blood clotting, or possibly suture, staples, or glue.
Okay. So that's what you would usually see where the two edges of the wound are together. And so surgical wounds are like that unless there was a chunk cut out that wasn't linear. I mean, most surgical wounds are going to be well approximated. What about secondary intention healing?
The secondary, the wound is going to be kind of open, or the edges will be apart from each other. There will be a clot, but the clot is filled with a lot of granulation, which is very fragile tissue that if you touch it, it will bleed.
Okay. So that granulation actually looks like little buds, and it's growing new tissue. And so the use of like a wet to dry dressing will provide some debridement of materials that shouldn't be there, and will allow for some some granulation. Okay. What about third intention healing or tertiary?
So when edges are separated, let's see, granulation tissue from bottom up, but slower because of infection. They're going to bleed easier. Their skin grafts might be common. They're typically due to traumatic injuries. And like I said, there's a delayed closure.
Okay, so for some reason, it may be that you had a wound, not a disseration, but dehiscence. There may be something, maybe it was infected, and then that actually, you're actually doing this secondary, you're doing the wound packing, and then later they would come back and do a closure versus it having to wait. So at some point, it'll be ready to be fully closed. Actions done before administering antibiotics for a wound infection.
So you always want to do a culture and sensitivity, and while you're waiting for those results, you'll start with a broad spectrum, which is like one of your cephalosporins. And when either with that or when you receive the culture and sensitivity, you'll give around-the-clock antibiotics for 10 to 14 days. And she specifically said look for signs and symptoms of a furry tongue and perineal itching. And
as a reaction to the medicine.
Yes, and antibiotics are excreted in the urine, so she said be careful with patients who have renal impairments.
Okay. So anytime a patient has renal or liver impairment, we have to be careful with the medicine. But making sure you have that culture and sensitivity done so that the medications can be adjusted once those results come back. Because otherwise you're just treating in general and it may not be effective to actually address the infection. Okay, so this is about pain. So did I miss anybody? Okay, so pain. Pain, I gave somebody transduction and transmission. Okay.
So transduction is the conversion of a stimuli into the neural action potential. And those include mechanical, thermal, and chemical stimulus. So basically, you have a stimulus that causes tissue damage, releases chemicals, which activates the peripheral apparent nociceptors, which fires your action potential to the spinal cord. And then,
so how is that that firing? Is that? You guys can chime in.
So I think that's not in the right order though, because it should be transduction, transmission, perception, and then modulation. Modulation is when it's done like that.
Okay. But what about transduction and that last process? How does that go through your slide sets on that, see what they have kind of listed as important things to know.
It's just the online slides.
Which one are we talking about? Transduction. What was the question?
The question was just describing that process of transduction. I know you talked about it, but the process of actually occurring.
Does it work with noxious stimuli, then tissue damage, release of chemicals, activate EAN, and then fire the action potential?
Okay, so firing, so electrical impulses, firing that. Okay, so noxious stimuli, starts with noxious stimuli. What about transmission?
that's just the movement of the painful impulse to the brain. And then she said that the neurotransmitter substance P is believed to be responsible for the pain transmission up to the spinal cord. Up the spinal cord.
Okay, and then perception and modulation.
Perception, pain is recognized and defined and responded to, and that is dependent upon the pain in its site. And then modulation is the descending symptoms. Neurons send signals down the spinal column to release various substances, and it inhibits the nociceptive ascending impulses. And the examples of it sending down the spinal cord, this is what I just heard her say from lecture, was that it includes serotonin and prostaglandin.
Okay, so I would think that perception still comes last because that's what's going to happen when the person is receiving pain. So I'm not sure how they listed the slides in that.
In her lecture, she said perception was in the brain. So perception is like your brain accepting the stimulus and figuring out what it
Yeah, like it
is,
transmits
and
up
then
and then you perceive it, and then modulation is it going back down.
Modulation is like its response after it receives the
Okay, I see what you're saying. Okay. So definitely go with what you guys have in your notes. Does everybody have the slide sets for that? Okay. And pain medication tolerance and appropriate nursing actions.
Oh, I have the chronic versus acute.
Okay, chronic versus acute pain.
I have the acute is the onset is rapid. It has external agent or disease process. It's mild to moderate, up to 6 months. And you can identify painful versus non-painful areas. The pattern is self-limited or readily corrected. Course is suffering decreases over time. Action is to relieve pain. Prognosis is eventually complete. And then the treatment would be analgesic for acute. And then for chronic, I have it's sudden or insidious, unknown or ineffective treatment. It's difficult to evaluate. It's prolonged. difficult to distinguish pain from non-pain. The pattern is continuous or intermittent. The course of suffering usually increases over time. Actions modify the pain experience. Prognosis is complete relief, not usually possible. And the treatment for opioid
treatment, okay. Okay. And yeah, this affects the person's entire life. Okay. Describe breakthrough pain. Did we do pain tolerance already?
No.
Okay, pain tolerance and appropriate nursing actions.
So pain tolerance is neuroadaptive mechanism characterized by decreasing effects of the drug at a constant dose or the need for higher doses to maintain an effect. So appropriate nursing actions, I guess, would be reevaluating the patient and I guess using a pain scale, verbal report, and then an increasing amount of medication required to relieve the pain.
Right. It really is about nursing advocacy at this point, because this is an area where you'll hear and report a lot of judgment from nurses, and they don't recognize that the patient has pain tolerance. So pain control for chronic pain needs to have a long-acting as well as a medication for short-acting, and they may not have that, so it may require an increased dosing amount. It may require an addition of a long-acting medicine or an increase in the frequency. But it's believing that patient and advocating for that patient that they're not addicted, but they've developed a tolerance.
You mentioned that in lecture,
Yeah.
that we should not confuse tolerance with addiction.
Right. Okay. What about breakthrough pain and appropriate nursing actions?
Breakthrough pain is pain occurring above what has been prescribed for pain, and it would be PRA meds, so breakthrough meds are given if regular meds are not working.
Right. So that's, again, if a person's having a lot of breakthrough pain, that means, again, increase in dose, increase in frequency, and also making sure that person has a long-acting pain med that will cover them. So, for example, did you guys talk about PCA? So in the hospital, they would have something where, what would be the long-acting, like how, if the patient was having a lot of breakthrough pain, what would make sure, I mean, they're pushing the button when they need it, but what else do they need?
What about the basal rate?
The basal rate. They're going to need some sort of a consistent infusion of pain medicine that they're receiving, and then they're pushing the button for breakthrough pain. So that would happen IV through the PCA or orally if the patient, you know, again, if they're able to take oral medicines. We do a lot of patches in hospice care where the patient's receiving long-acting patches, fentanyl patches that last for 3 days, and then we're treating their breakthrough pain with shorter-acting pain medicine. So making sure they have that continuous infusion going with the PCA. So what about the nurse's role in analgesic titration?
Okay, she said that very frequently a doctor will say to you that he wants he will write you an order like 0.4 to 5 to 1.5 PRN pain 2 hours. It is up to the nurse to decide how to keep that. If the person is getting good relief from 0.4, why are you going to give the person 1.5? You need to go to the mark and see what the dose was the last time that was given. If the person doesn't have no pain, means that the dose is perfect.
Okay.
Don't give
So
it's
it's basically saying if they have good control, you don't need to give medicine. So analgesic titration is done where they're making adjustments in the medications, and part of it is helping that, educating the patient finding out from them, is this working, communicating with the physician regarding symptoms and letting them know about expected symptom relief as well as side effects. So, and then differences in pain medicine when consideration when caring for hospice patients. Most of our patients develop pain tolerance, and so we don't really have this threshold that we're saying, okay, we're not going to get it this high. Many people receive high doses of narcotics, and oftentimes people would prefer the sedative effect to medication to relieve their symptoms versus being, and it's based on the person, but sometimes they get so much that they're very, very sleepy. The other is that even the vital signs, for example, even with respiratory rates that are low, if the patient is still having pain symptoms, we do need to go ahead and give those pain medications. If it's done correctly, which is done in small increments like we do, it's not going to be the morphine that basically expedites the person's death. It's going to be their disease process. So we do give medications even with lower respiratory rates because they actually may be just dying of natural causes. So,
I have a couple questions
Sure.
about it. Could you explain operant conditioning?
Okay. So operant conditioning, I'm thinking that's Skinner. How is that related
I think it's like
to what you guys are
positive.
studying?
It was in her lecture. It's like
Regarding-
positive.
Pain. Is it?
No, like she used it.
Which topic do you want to do?
Was
It's
it in
pain.
the online one or the in-class one?
In class.
Right. I would have to look back, but I believe that's, if you guys can even look on your
It just
cell phone,
says
I believe that's
reward and
D.S.
praise for
Skinner.
pain work.
And what they do is it's based on a
Yeah.
reward. Is that, do you guys have any notes
Yeah.
about that?
I just have reward and praise for pain work. Like,
Right, so that, I think that's, because the focus is going to be pain control. This is not a test on developmental behavior or anything, so your focus needs to be on, basically what it's saying is positive reinforcement.
Okay.
So positive reinforcement, for example, he did research where, he would give like an animal a treat, for doing what it was, like a trick like that. And that's how he came up with the idea of operant conditioning.
Okay.
But it's the idea of reinforcing behavior.
Okay.
So did you guys find anything else on that was in your slide set?
She didn't really explain it, and I looked it up. I just didn't know how it really corresponded with pain.
I'm not really sure how it does either.
Okay.
But other than, you had mentioned though, that how did she explain it?
I don't know if she worded exactly this way, but I just said reward and praise for pain work.
Okay.
And she said it reminded her of that
Okay.
dog
Okay.
Yeah.
thing.
Yeah, I wouldn't get too focused
Yeah.
in on that because I don't really think
Okay.
it's related to what you guys will be tested on. Okay. So what is the nurse's first action when beginning client education? A, begins teaching sessions as soon as possible prior to discharge. Can somebody catch that light? And then B is determine client interest in learning prior to initiation of teaching sessions. C, assesses client learning capabilities as well as those of family members and the group. As a group, and if client shows no interest in learning, documents a temp and notifies healthcare providers. So which ones can we get rid of? There any that we can get rid of? Okay, so this is key right here. First action. So your first action.
It's always assess, right?
So would we do A? No, because we want to find out more about things before we just begin teaching. And so what about this one? Could this be a possibility? Determine the interest in learning?
Yes.
Okay. And then assesses the client's learning capabilities as well as those of his family members. That could also be a potential. And then this one, this also is called what's called passing the buck, which anytime you don't actually address something and you're just contacting the health care provider and you're not addressing the patient's needs, again, you may notify the health care provider, but you want to make the assessment first. So which do you think of B or C would be done first?
C.
Okay, I think you have this here because of assessment. This is also really an assessment too. So
It's gonna be B.
it could be B or C. So, okay, because if they don't care about learning, it doesn't really matter about their learning. They have to actually want to learn something, and so many people actually don't. So what is their interest in learning first, and then what is their capability? So what's their interest, what's their motivation for learning, and then what are their capabilities would come second. Okay. The nurse is initiating a series of teaching sessions with an older client, so the highest priority action prior to beginning the session. So ensure that the client's family are present and will participate. Make certain the client is wearing his glasses. Have printed handouts ready to use. Schedule the session for early evening after the client's meal and before his medication. So what do you guys think is the most important? Okay. Okay, so I have printed handouts, which is not the ideal for teaching sessions except for if they're specific for that particular patient. Most printed handouts are going to be problematic with an older patient because they're not the right text.
So if it's an older adult, I just don't want to assume that they have family that is going to help them.
Right,
But
right.
normally I would have said A.
Right. Okay. What about B?
Yeah.
So one of the things that we know about older adults, and you know have this from OA, is that there's some decreases in visual acuity, and we already know he wears glasses because it says his glasses. So he's not going to be able to learn anything without his glasses on. So we want to address that specific before we do anything else. Okay. Oh, actually, okay. Well, I don't. You know what? That's where that darn thing got lost into. Remember, I had the thing that said pain. Somehow it got dislodged from that slide and got put there. I kept wondering where it went to. So, this is an adult with type 2 diabetes after being admitted to the hospital with an infected foot wound. What principles of adult learning, when applying the principles of adult learning, which teaching strategy is the nurse most likely to be effective? So determine the importance of blood glucose and maintenance of long-term health. Demonstrate the correct method for cleaning and redressing the wound to the patient. C is assure the patient that the nurse is an expert on the management of diabetes complications. D is wait until after discharge and have a home health nurse teach about foot care and diabetes. So which ones can we get rid of right away? D. So D, what other one? C. So it's really between A and B, and we'll see what you say. That would be a good select all that apply, wouldn't it? Okay. So I think the key here was based on the principles of adult learning. So that psychomotor learning where you're actually demonstrating and doing a return demonstration. A lot of people don't want to listen to a lecture, and so that may be what that is seen. Let's see.
I think too also if he's had diabetes for a while, he's going to kind of know the importance of checking.
Yeah. Oh, yeah, because he has an effective foot wound. So
Right.
he's had diabetes for a while. He knows what he
How to
needs,
take care of the
but he's
diabetes.
not doing
Not
it.
sure
So
how
it's
to do it.
behavioral, or it's actually behavioral.
And it's more on
So-
like the infected foot wound, not like
Right,
monitoring his
exactly,
levels.
exactly.
I thought adult learning was the how and why.
Yeah, that's what I got confused too.
Okay, but it's the how. The how is this piece here, demonstrating.
But wouldn't the why be the importance of it?
I guess Siri thought I was talking. But what it is that this patient already knows about diabetes because they have a long-term history of diabetes. You don't get a foot wound, you don't get an infected foot wound typically with diabetes. I mean, that there's always exceptions, but by the time they get an infected foot wound, they should know how about that. I'm not saying that, I mean, A is actually a very good answer as well. So that, I mean, that would be a great, like I said, select all that apply. So both of those are actually very good, but
But if you only did
one
one.
is the demonstration, because what you're doing is treating that infected foot wound, okay?
But you're also demonstrating it. You're not having them demonstrate
Right,
it.
it really should say, you would demonstrate first and then have them do a return demonstration, that's ideal. Okay, so assess readiness to learn before planning activities. Which questions should the nurse ask? So what kind of work and leisure activities do you do? What information do you think you need to know right now? Do you have any religious beliefs that are inconsistent with treatment? And can you describe the types of activities that help you learn new information? So what do you think is the most important one?
D.
Okay, so D is a possibility
Isn't that planning teaching activities though?
before planning. Okay, but again, you have to go, this is an assessment. What would be like the first thing you would do in an assessment? I would do, I mean, we'll see what it is. I would do B because that's all about what do they know and don't know first.
If it was asking how are you going to plan teaching activities,
Right.
then it would be D.
Yeah. So when assess the readiness, okay, that's the key right there, to assess the readiness to learn. So the readiness is assessed by what information do you need to know right now. And that's what's really, it has planning, so it says before planning. So then with the planning, that would be part of the planning. So if you've seen this before, the Kaplan decision tree, that would be an assessment versus implementation question. And this is an assessment question first, and then the next thing you would do D. So hopefully I'm not wrong here. So motivation.